I'm Michael Pauley, and this is Faith in Politics. On this broadcast, we range from the soul to the state as we cultivate those virtues and explore those principles that help us live well as faithful Catholics in this great land.
Well, welcome back, everyone. It's great to be doing another edition of Faith in Politics. I've had to take a little hiatus for a while due to the work related to the legislative session in Pierre. As we're recording this broadcast today, it is the 14th day of the legislative session, and this is the time where things really start to pick up pace. Most of the bills that legislators plan to introduce have been introduced by now. A lot of them are clearing through committee and going to the floor votes, and so it's a busy time, and we work long days. And one of the bills that the South Dakota Catholic Conference is working on is legislation called House Bill 1080, also known as the Help Not Harm Bill. And this legislation deals with this growing phenomena of so-called gender transition procedures. And so what the bill does is it prohibits the administration of puberty blockers, cross-sex hormones, and certain specified surgeries if done for the purpose of trying to validate a minor's perception of being a sex other than their biological sex. So this bill was heard before the House Health and Human Services Committee this morning. There was a lot of very impassioned testimony from both proponents and opponents of the bill. I spoke briefly on that bill on behalf of the Catholic Conference. And the good news that I'll share is that that bill was passed out of committee by a vote of 11-2. So it was very gratifying to see that decisive margin for the bill. And it will probably be considered on the House floor in the next few days. So just an update there on a real critical bill in the state capitol. So today, I want to dedicate this episode of Faith in Politics to exploring this whole realm of gender ideology and particularly gender ideology as it manifests itself in this whole area of so-called gender transition procedures. And I have a special guest today to talk with about this issue, Dr. Al Oliva. Dr. Oliva is a board-certified plastic surgeon who specializes in microsurgery and has been in private practice in Spokane, Washington for 30 years. He was the senior partner of Plastic Surgery Northwest, which is a group dedicated to microvascular reconstruction. Dr. Oliva is on the board of directors of Walk for Life Northwest, and he has also held leadership positions on the Catholic Medical Association and now serves on the executive board of that organization. He's been a great public witness for advocating for the dignity of all human life from conception to natural death. Dr. Oliva, welcome to the program.
Michael, thank you very much. Thank you for having me.
Thank you. And I want to share with our listeners, in the spirit of full disclosure, that my wife and I have known Dr. Oliva and his wife and family for many, many years. They're dear friends. And so probably in this broadcast, I'm going to just slip and start calling you Al. And I just ask the listeners, I'm not being rudely informal, but we've been friends for a long time. And so it's just a pleasure to have a conversation about this subject on which you have so much expertise. So just to start off with, in one of our previous conversations, I learned from you, Al, that you gave an address last year in Rome to an international gathering of Catholic medical societies. And the subject of your talk was the surgical treatments of adult gender dysphoria. So you've done a lot of research on this topic. And I guess I just want to ask to start with, how did you develop an interest in this whole subject area?
Well, I'll try to give you a short answer, but first, let me just say that the International Society of Catholic Physicians, FIAC, it's a synonym of a string of French words, but basically it's an organization of all Catholic physician organizations throughout the world, and they meet every 4 years, and this year it was in Rome on Vatican property. It was an excellent opportunity to meet Catholic physicians from throughout the entire world, especially those from the Ukraine. And so the topic for this meeting was transhumanism and how we are changing our human nature, and a lot was said about robotics, artificial intelligence, and I was asked to speak on, obviously, the transitioning that we're trying to do in human beings from changing our biological sex to what we identify as our gender, and how we do that surgically. And that piqued a great deal of interest in me from a technical aspect, because a lot of these procedures are complicated and require microsurgical expertise, which is the transfer of tissue from one part of the body to another to create form or function, as we've done for cancer, trauma victims. We currently, in our practice, use it mainly for breast cancer reconstruction. So I started to look at all of this, first of all, from a technical aspect, and then realized that the medical literature on the topic really is not very bountiful, let's say. There's not a lot of literature that actually describes more than the technique. In other words, what the lifestyle of these patients are, and the suffering that they go through, and how now they're tied to the medical establishment for the rest of their lives. And if I may say so, this is a group of individuals that needs our love, care, and compassion more than any other group that I can think of, because they suffer greatly in thinking that they are in the wrong biological body. And this causes a great deal of anxiety and depression. And so the most important thing is for us to help them, not to lead them down some rabbit hole thinking that by changing the appearance of their bodies that they're going to somehow be relieved of these very complicated, complex psychological disturbances that they have.
Yeah. So speaking of the issue of psychology, what does science tell us about the origin of gender dysphoria? Is this fundamentally a psychological issue, or is there a genetic root to this phenomenon?
Well, if we look back historically, let's say 10, 15 years ago, the majority of children that felt this angst of being in the wrong body was quite small, something like 0.003%, and it was seen in pre-pubertal boys. In other words, little boys who had not gone through puberty. Fast forward to the current situation, and what we're seeing is a huge shift, and also noted by the Center for Disease Control, of 20 to 40% fold increase in the last decade. But now it is not prepubescent boys, but rather it's post-pubertal girls. So it's girls that have just entered puberty or just finishing puberty. 12, 13-year-old girls are making this cohort, which had not been seen before. And so several theories have now come out. Is this simply because society is more accepting of this transgenderism, or is it because there is a social contagion attached to it that it's actually not a stigma to be trans, but actually a bonus? And there are certain there are certain societal benefits that one gets in school and being cool and being part of a group. And so researchers have now found and have written a paper called Rapid Onset Transgender Dysphoria that shows that, parents are attesting that their children never had any of these dysphoric feelings about their sex, but then as they were part of a group where other girls might have felt that they were trans, then their daughters also had the same inkling, and more girls in these groups started to have the same thing. And there are numerous social media sites that encourage children to transition and basically explain that, the difficulties you're having while you're transitioning in puberty, well, that's simply because you really are of the opposite sex. And if you would just get a hold of that, you would see all of these psychological feelings about being an adolescent would diminish and possibly go away.
Yeah. And I'm certainly not a medical expert in this field, but just as a layman, sort of trying to use common sense, it's really hard to imagine a physiological explanation for how you could see this sudden shift from reported gender dysphoria cases being primarily young boys to shifting to adolescent girls in such an incredibly abrupt time frame. Can you think of any physiological explanation for why we might see that phenomenon?
No, physiologically, I really can't. And I think the reports of parents who say, my child never had any of these types of feelings or these psychological issues we never saw. We thought our kid was a happy kid, and now all of this is changing. I will point to the science of Dr. Milton Diamond. And Dr. Diamond studied monozygotic twins. Those are, layman's term, those are identical twins. In other words, they came from one egg and sperm that split and created two individuals. So genetically, they're 99.9% genetically identical. And so those twins, if you follow them, they will have the same height and weight within 90 percentile. They'll have the same color hair, the same color eyes. Many will be indistinguishable in terms of their physical characteristics. And this is because of genetics. So if gender dysphoria was linked to a genetic code, then you would expect that these monozygotic twins, as they aged, would have a high concordance rate for being transgender. Well, Dr. Diamond found out that that's not the case. The concordance rate was 28% in his twin studies, and he's done several of these studies. And so it leads to the conclusion that there is more of an environmental factor, experiences that are not shared genetically within the womb or immediately after, but are actually experiences that are shared differently in households, and that's why the concordance rate is low at 28%. So it seems to point to environmental factors of what happens to these children rather than some innate genetic predisposition.
Okay, no, that makes sense. So what I want to do is segue to your area of specialty, and not that you're involved in transgender surgery, but you're plastic surgeon, and this is surgical procedures are obviously one of the things that is being done in response to gender dysphoria. And it seems to me that regardless of how you view these surgeries from a moral point of view, that they can fairly be described as radical. And what I mean by the use of that word is that we're talking about surgeries that remove perfectly healthy and functioning parts of the body. And when I try to think in my brain, to what other area of medicine would you actually remove health? Usually you're talking about removing diseased tissue or cancerous tissue, but in this case, we're talking about removing perfectly healthy and functioning parts of the body, sometimes producing irreversible consequences, sterilization, disfigurement. And yet, and we heard this in the testimony today on the bill in South Dakota, this whole array of medical professional societies seemingly has embraced this concept of gender affirming care, including these surgeries with irreversible consequences. So I guess I just want to throw that out there and ask for your thoughts on this. Is this just the logical outcome of divorcing the practice of medicine from any kind of objective moral or ethical standards?
That's a good and difficult question of the true etiology. I think it all started with misplaced compassion, that surgeons wanted to help people with dysphoria, thinking that they could be alleviated of this problem. The fact is, though, if we look at the historical science, what's published in gender dysphoria is that 86 to 90% of children historically with gender dysphoria would desist after going through puberty. So, and we just don't make any, we just don't focus on that enough, so that if we're saying that 85 to 90% of children would actually not have this feeling of dysphoria if you just counseled them, loved them, took care of them in families, then why are we treating so many children with life-altering medications of whose consequences we don't know? So when little boys are given estrogen before they before they go through puberty, we know that this is going to have a detrimental effect on their bones. But to what degree, we don't know. Can it cause bone cancer? Can it cause a male breast cancer? We don't know. We think it could, and we won't know for another 20 or 30 years. But why are we doing that when the vast majority will desist and not have these issues? Similarly, when we give testosterone to prepubescent girls or postpubescent girls, it stops their periods, and it gives them kind of a jolt in the arm. It gives them a little bit better muscle producing capabilities, and it gives them psychologically a euphoria. And that's interpreted that, this is exactly what they needed. They needed to transition, and the proof is that they're feeling better. Well, that's a temporary relief. And, exactly what testosterone does to a young girl long term, we just don't know. But they're going to have to be on these hormone supplements for the rest of their lives. They're intrinsically linked to the medical healthcare system forever. And these are normal people that really didn't require any of these drugs. And most of them, without these drugs, would desist and not have gender dysphoria. So how did we get there? Well, the results with transitioning surgery in adults were very poor. So the thought was, well, if we would start when these adults were children, if we treated them when they were children, then we could offset the secondary sexual characteristics which make it more difficult when they're adults to change. Like what? Like forehead bossing, a deeper voice, all of these changes. So that if we were to do this when they were young, then maybe the results would be better. Unfortunately, as we say, we're only talking about 15% of children with gender dysphoria. 85% or more don't need any treatment other than care, love, affection, the warmth and security of a family.
Yeah.
So and I didn't answer completely your questions of what's involved, but that's how we've gotten there. And it's this misplaced idea that anyone can be whatever they want. It's kind of a detachment from the reality that there's an absolute truth and that there's absolutes in society, that things are right and things are wrong. And we've adopted this ideology that sexuality is fluid and there really is no absolute, and whatever we seem to think is pleasurable should be allowable.
Yeah. No, I think your diagnosis is exactly right. There's deep philosophical roots to this ideology. There's this sense that our biological sex is not something that is just given, but that it's willed. You can will yourself to be a sex other than what you obviously are based upon your chromosomes. So when we talk about medical organizations that are, I guess, if you will, captivated by this ideology, one of the first ones that comes to mind for me is this organization called WPATH. That stands for the World Professional Association of Transgender Health. And this organization has advanced what they describe as standards of care for treating gender dysphoria. Can you just comment a little bit on what does this organization do and why are they significant in the whole controversy?
Well, that's a very interesting point, that WPATH had its origin among transitioners. That's how the organization started. A group of transitioners who met, I believe, in Copenhagen or Amsterdam, I don't recall right now, and said, we should develop standards for people who want to transition. So it's an activist group that is fully on board with transitioning children and adults. And so you wonder why they all of a sudden are the center of truth when it comes to transgender medicine, because they're completely biased. They don't look at any of the scientific data to say, wait a minute, like they don't look at the desist data, or they just ignore it. Just as now they're ignoring the detransitioners. There's a group of detransitioners, and WPATH completely ignores their plight. Shouldn't they be helped to go back to the original sex that they felt was correct for them, that they made a mistake? What's really disturbing now is that the standards of care have been revised, and during the last revision 8, which happened this year, WPATH has completely decided to get rid of all of its restrictions in terms of age. Before, you needed to be 14 years old for cross-sex hormones. They've gotten rid of that. Before, they suggested you were 15 years old for double mastectomies. They've gotten rid of that age. Before, they thought you should be 16 years old for breast implants or facial feminization surgery. They've gotten rid of that. They thought you should be 17 years old before you had genital surgery, and they've gotten rid of that as well. So they've become more and more radical as time has gone on. But the last recommendations are just bizarre, absolutely bizarre. And it's leading to this idea that now you can do genital surgery on children with questionable parental consent. And the issue of consent is important. How does a child understand that in the future they will be sterile, that their sexual function in terms of just pleasure from sex might be completely altered, and that all of this is irreversible? So how is a child supposed to understand that? Or even parents who want their children to be happy, how are they really making a decision that is so far into the future about what is going to happen? Again, when the vast majority of these children, if you left them alone, would be able to have sexual function in the future, would be able to have children if they wanted to in the future, and yet we're stealing that from them over an ideology. Not even over any scientific fact, over an ideology. In fact, the science points you in the opposite direction.
Yeah. Well, and it's interesting when you contemplate the vast array of our laws that we have related to minors. We have laws that say that underage people cannot consent to marriage, even on occasions when the parent would be okay with it. But we say, at a certain age, you're too young to consent to a marriage. You're too young to sign a contract, too young to vote, too young to buy alcohol and tobacco. And we could go on and just name this whole laundry list of laws that are established frankly, to protect minors from their own immaturity. And we never question this in other contexts. But in this particular context, when we're talking about, literally amputating perfectly healthy parts of the body and taking drugs with unknown long-term consequences, then suddenly we say, minors know what they're doing. And it's really strikes me as a remarkable double standard. So, well, I want to talk with you a little bit more about WPATH, but for our radio listening audience, we are coming up towards the end of our time here, but we are going to continue the conversation with Dr. Al Oliva. And if you would like to hear that whole unabridged conversation, the podcast will soon be available on the website of the South Dakota Catholic Conference. That is sdcatholicconference.org. So again, please go there to see the rest of the conversation. But for our radio listening audience, until next time, live well. All right. And for the lucky podcast audience that gets to listen to the unabridged conversation, Al, I want to ask you about a group that I stumbled across as I was researching this subject. It is called the Society for Evidence-Based Gender Medicine. And I had not even heard of this group a year ago, but in the process of researching the WPATH guidelines that you were just talking about, I found some, frankly, rather harsh critiques of their guidelines by this group, the Society for Evidence-Based Gender Medicine. So can you share a little bit about this group and why is their involvement so important?
Well, they go by the name SGEM, Society of Gender Evidence-Based Medicine, and that's exactly their goal. Their goal is simply to say, okay, what is the evidence? Let's put all of this ideology aside. If we're really serious about helping people, we should try to have medical evidence to show what is beneficial and what is harmful. And that, I think, is their entire goal. They're a group mainly of academicians who see what's going on for what it truly is, an ideology that is supplanted basic medical science. And, I came across them first when I was researching an article that was written in the American Journal of Psychiatry in 2019, and it was written as a paper from the Karolinska Institute and Yale University. All right, and this paper was written by a Dr. Brandstrom from the Karolinska and a Dr. Pachinkis from Yale. And basically, they suggested that their paper lent, quote, strong support in providing gender-affirming care. And in fact, the lead author from Yale said that, quote, no longer can we say that we lack high-quality evidence of the benefits of providing gender-affirming surgery to transgender individuals who seek them. So those are strong statements to make. Well, guess what? The Society for Evidence-Based Medicine reviewed the paper and found that the data actually showed the opposite, that there was no evidence that providing surgical care changed any outcome in terms of psychological benefits. In fact, the data showed exactly the opposite of the conclusions. And so the Karolinska Institute then provided a retraction to that article. The American Society of Psychiatry issued a retraction, and so did Yale University. However, that information had been on social media for several months. Yeah. And so this is the kind of what we're seeing in medicine today, that people are blatantly concluding falsely based on their own evidence of what is beneficial in transgender medicine. Something I thought we'd never see in medicine, that people would frankly falsify their results. And it's groups like the Society of Evidence-Based Medicine that are putting things straight. Yeah. The same thing recently happened at the University of Washington, here in Washington State, in the pediatric department at the Children's Hospital. A paper was written that psychological benefits were shown in transitioning and giving transsex hormones to children. The evidence was reviewed and found to be completely false. Wow. Very few mainstream writers, there are a few that have written on this, but mainly it goes by the sidelines. Once the headline is there, the social media picks it up and distributes it, even though it's false. So we need groups like the Society for Evidence-Based Gender Medicine, because we need to know what the truth is.
Yeah. Well, hearing you describe this process reminds me of that old expression that I can't remember exactly how it goes, but it's something like a lie can make it around the world 5 times before the truth even gets its pants on. And it always does seem like we're playing catch up on these things. And I think you pinpointed it right, that social media and the instant information age we live in, there's blessings to it, but there's also just this huge danger that somebody puts a study out there that is basically junk science, but it can dominate the headlines and shape cultural attitudes and public opinion, and it may be complete bunk, but the process of identifying it, the methodological flaws can take such a long time, and then by the time it's reported, then the damage is already done. So I want to. Did you have another comment?
Well, I just wanted to point out that there is data out there, and I think we need to take a hard look at the Scandinavian countries. It was the Dutch protocol from the Netherlands that started this idea of transitioning children, not from any scientific evidence, but simply because this is what their philosophy was on treating children. And now that's come under attack. The Journal of Sex and Marital Therapy that I just saw, there's an article by a James Cantor, who fact-checked the American Academy of Pediatrics for taking on the Dutch protocol when there was no science. So now people are pushing back and are saying, wait a minute, let's really go back and look at what the Dutch protocol was about and how other countries in Europe are backing off from it, while here in the United States we're pushing forward. You may have heard of the Tavistock Clinic in London that was closed down. Again, this was a transitioning clinic for children, found to be completely abusive of children because there was no psychological counseling at all. And even WPATH says that, you can't transition children who are psychologically distraught. You have to try to counsel them first before you take on all these therapies. And that wasn't happening in London, and it doesn't basically happen in any of the clinics in the United States either. A child simply claims that they're transgender, and immediately they go on to a protocol without any evaluation of whether that's true. And if the parents ask any questions, well, they're suspect too, because they're advocating for their own children. So now the data is coming out, and when you look at the Scandinavian countries who have been transitioning patients for a very long time, if we look at the outcomes of patients, adults who have transitioned surgically and follow them for 10 years. So this is a long follow-up of 10 years after they've transitioned, and we see how are they doing psychologically. Well, we note that the suicide rate, the completed suicide rate for these really distraught individuals is 19 times the suicide rate of their cohorts in the Scandinavian countries. And if we look at male to female transitioners, it's 40 times. So the data shows that, it didn't help them psychologically to transition. Whatever these psychological demons are, they're still there, they still persist. Surgery provides a momentary relief for several years, but if you follow them down the line, the completed suicide rate is extremely, extremely high. And so now we're starting to see that, and we're starting to see the Scandinavian countries who have a socialized medical system and have the data readily available in a database, a longitudinal database. They're now saying, wait a minute, is this the best way for us to spend healthcare dollars? So now Sweden, Finland, the UK, and even France have put the brakes on transitioning children.
Yeah.
And so because they see that the psychological benefits aren't there, and there is an expenditure of limited capital for these countries with socialized medicine. So that should be a warning for us in the United States about what we're doing. Yet we're doing the opposite. The American Academy of Pediatrics is gung-ho on transitioning children. And to do so is considered a nearly malpractice in the United States. I will also say that in a pushback to the American Academy of Pediatrics, we have the founding of the American College of Pediatricians. These are pediatricians who actually read the data and see that this transitioning is harming children, not helping them. And therefore, they've created a professional society of board-certified pediatricians, a lot of them pediatric endocrinologists who know about hormones, to push back and say, no, look at the data from the Scandinavian countries. We should not be transitioning children, especially since the historical data shows that over 85% of them will desist if we just counsel them, love them, and take care of them.
Yeah. Well, I want to ask a little bit about the specifics of the surgeries that are involved in these so-called gender reassignment procedures. And I need to provide a trigger warning to sensitive listeners, especially if you're a parent with young children nearby. This is not necessarily a pleasant topic to discuss, but I think it's important, for the sake of honesty, that we talk about what these surgeries actually do to alter the physical appearance of people with gender dysphoria. I think we just need to look these problems in the eye, and before we can really know how to respond appropriately. So with that being said, can you just explain what things are done surgically as part of these procedures? And I guess maybe just to lead off, if it's a male who is attempting to appear biologically as a female, what types of procedures are actually done?
Well, from a male to female, that's the easier approach. And
relatively speaking.
Relatively speaking, because basically what you're doing is you're removing the penis but saving a large portion of its skin. Then you're removing the testicles and using the scrotum to make a neovagina, to involute that into the pelvis. And of course, the issue is always that the vaginal canal will be short and not lengthy enough. There have been other ways to create a vagina using even part of the large intestine, but that has a much higher complication rate. And of course, along with that, then there would be a continuing hormonal therapy, so that then the breasts would be augmented later or at the same time. Then there would be correction of the facial features to make it look more feminine, including the brows, even surgery on the vocal cords to make the voice less deep. And those would be the basic issues. But make no mistake about it, it's a penectomy. You're removing the penis, and that's not easily reversed. It's permanent. It's permanent. Sterility would be permanent. Yes, because of the testicular removal. Yes. Yeah. Sterility is there for sure.
Yeah, and then if we could just talk about the other side, surgeries that are done upon biological females who are trying to take on the appearance of a male. That's a little more complicated, as I understand.
Yes, very, very much more complicated, because now we have to create a phallus, a penis, and what's typically done is a large section of the forearm, both the volar and dorsal side, meaning both sides of the forearm, that tissue, that skin is removed along with the blood vessels that connect to it, the radial artery and veins, and that tissue is then made into a tube, but then the urethra that connects the urine from the bladder to the tip of the penis has to be created as well. And so it's basically a tube within a tube, and this requires microvascular expertise, because that tissue has to be transplanted to the perineum, and blood vessels need to be connected using a microscope and suture material finer than hair. Now,
Wow.
the difficulty here is that the urethra in a woman is only 3 centimeters or so, and now you have to connect that all the way to the tip of the penis, and so the urethra is of skin, but typically it's of mucosa. So there's a difference there in the complication. Over 65% of patients who have these surgeries end up with either a urethral stricture, which is a contraction within the tubing of the urethra, or with a fistula where the urine actually leaks from the bottom of the penis. So that's the real difficulty in this female to male surgery. And then you have to create a scrotum, and that can be done with part of the vagina or with prosthesis as well. The penis, of course, is going to have some type of erectile instrument, some type of an implant that could be inflated with air to provide an erection. But this does not mean that there's the same kind of sexual function that a normal male would have. There would be really no true sexual function to it. Another alternative is to simply give enough testosterone so that the clitoris can actually become elongated by a few centimeters, not very long, and some female to male patients choose not to have a phallus created at all and simply have this pseudo penis in terms of an elongated clitoris to avoid all the complications of the urethra that's associated with creating a real phallus.
So there's obviously just this wide array of these, I guess, call them amputations or castrations, for lack of a better word, and then reconstructing these sort of facsimiles, I guess, of authentic organs. They're not actually real organs, but just these attempted facsimiles. What kind of complication rates, and I recognize it's probably different for each one of these procedures, but can you just, to give our listening audience some perspective, what would be typical complication rates for some of these things?
Well, again, the greatest complication rates are from female to male, and urethral stricture is over 65% if you're creating a phallus. But if you're just using the clitoris, an enlarged clitoris, it's still around 63%. And then the fistula, we have an abnormal communication from the urethra out of the skin, so that urine would be leaking through the base of the penis. For the phalloplasty, it's about 27 to 30%. So, revision surgery in these procedures are over 75%, that you need more than a procedure to correct the complications. Many of these female to male patients, they're seeking to be able to urinate from in a standing position. So that's a goal for them, and that's why the phalloplasty is something that they would search out, despite the high complication rate from the urological part of the operation.
Okay, so I want to ask you, what to me seems like an obvious question that everybody should be asking at this point, which is we're talking about elective procedures here. These are procedures that are chosen. We're not treating a disease or removing a cancer or anything like that. This is an elective procedure. can you think of any other elective procedures where complication rates this high would be tolerated?
No. Even other, in other surgical procedures, I mean, if a complication rate is 60% or more, I think you have to revisit the entire operation. I can't think of any surgical procedures that has that kind of high complication rate.
Yeah. That's the first thought that comes to my mind, is that if your life is at stake, then a procedure that has a 50-50 chance of saving your life, well, those, you might say, let's go for it. What do I have to lose? But when you're talking about, a purely elective procedure, these are astonishing numbers. So, well, that's about all the time we have for our program today. But Dr. Oliva, any final thoughts that you'd like to just share with our listeners, especially as regards, as I mentioned before, the big issue that we're talking about in South Dakota now is these kinds of procedures being done on minors. Just any final thoughts you can share on that subject with us?
Yes, I think we need to encourage families that their child is not going to commit suicide if they don't transition. That's a fallacy. It's not based on any clinical evidence at all. We need to encourage families to just love their children. Children who really feel dysphoria, you need our complete attention. They need all the resources that we have in loving them, counseling them, and taking care of them, and encouraging the family that 85% chance that this dysphoria will desist once they get through puberty. So we need to encourage them to listen to what is established science and not ideology, and not get caught up in this whirlwind that's going on right now that really threatens the livelihood of many, many children in the United States.
Very, very well said. Thank you. Well, thank you to all of our listeners. That's all the time we have for this episode of Faith and Politics. I do want to mention again, the bill that is being considered in South Dakota right now is House Bill 1080. And if you would like to get some more information on that, please visit the website of the South Dakota Catholic Conference. That is sdcatholicconference.org. And you can, on the homepage, you'll see a place where you can click on issues that are being discussed during the 2023 legislative session. And if you go there, that'll be the first item on the list is House Bill 1080. As I said, this bill will be on the House floor very soon, and then going over to the state Senate. So now is a great time to contact your legislator, send them an email, leave them a phone message, and urge their support for this common sense legislation that just protects vulnerable children from these harmful medical interventions. So again, thank you to everyone, and until next time, live well.